Good morning, Dr. Kidd. How are you?
Good morning. I'm well. Yourself?
Oh, just one. Sorry, I forget that this computer doesn't have sound. Good morning. Could you share your screen for a moment just to make sure that everything's running smoothly before the grand round starts?
Absolutely.
Oh, great. Okay, so it's working. Just making sure. So one of the chief residents will introduce you. And then after the introduction, you can start your grand rounds.
Okay.
So we have several people that ask us when they're supposed to start. So we like to give you the information so you'll know. But I look forward to listening to your grand rounds.
Thank you so much.
Thank you.
Good morning, everyone. I have 8 o'clock, so let's get started. Welcome to this week's Medicine Grand Rounds. Just a few reminders for everyone. Please ensure that your mics are muted to avoid any unintended interruption for our speaker today. Please ensure your full names on your Zoom login so you can easily be identified. If you're logged in as a group, please email Department of Medicine Grand Rounds at hsc.wvu.edu to receive credit for today's lecture. If you've not participated in and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. This ensures that we have the appropriate information on file for you. We will save time for questions at the end, and if you type your questions in the chat, we'll work to relay those to our speaker. We'll try and wrap up around 8:55 in order for everyone to get to their clinic duties. Today, I have the pleasure of introducing Dr. Casey Kidd. Dr. Kidd graduated from medical school in 2014 from WVU. She then went on to complete her internal medicine and pediatric residency here as well in 2018. She then left us to go complete an adolescent medicine fellowship and master's in clinical research at the University of Pittsburgh in 2021. After completing her training, she graciously came back and returned to us to serve as an assistant professor of adolescent medicine and medical director of the Children's Gender and Sexual Development Clinic. She has many publications contributing to the literature of adolescent medicine, gender diversity, and equality. Please join me in welcoming Dr. Casey Kidd.
Good morning. Thank you so much. Let me share my slides. So my name is Casey Kidd. I use she, her pronouns, and I'm very excited to be with you today to talk about gender affirming care for the internist. I have a few disclosures to go over. I don't have any financial disclosures, but I am a pediatric and a young adult gender affirming care physician and a researcher dedicated to improving health outcomes for gender diverse young people and their families. My own identities are complicated, but I need to acknowledge that I have a whole lot of cis het privilege, and that's important in this conversation today. I am the medical director of the WVU Medicine Children's Gender and Sexual Development Clinic. And so if you have patients who may be seeking care that you would like to refer, here's a list of things that we do. We do see patients up to age 26, and so many of our patients may overlap. I have 3 learning objectives for you today, and those are listed here. I want to evaluate language used in conversations and documentation with and about gender diverse people, identify ways to make this patient population feel safe, seen, and comfortable, and to also specifically define health concerns critical to the care of this patient population within the field of internal medicine. And we're going to do that through some case-based learning. Some of you may be thinking, okay, well, why is this necessary? And you may think, I treat everyone the same. And so there's no difference. Why do I need to be trained? You know, you can't change someone's attitude. And these thoughts, while completely reasonable, can also be problematic because of the idea of therapeutic neutrality. This attitude in the provider community specifically that everyone deserves, but also that everyone can receive the same quality of services. And that actually diverts attention away from access issues and issues in providing services to patient populations who have been historically and in modern day discriminated against, had access denied for a variety of reasons. And it's important that we recognize this because our lack of recognition further impedes the delivery of culturally relevant services to LGBTQ people more broadly. There's also an excellent paper in Annals of Internal Medicine that was published in 2019 by folks I have had the privilege of working with previously, Dr. Safer and Ting Pritcha. And this article is one that I highly recommend that everyone read if you have not yet already. I want to point out something in the abstract here that I thought was very appropriate for our talk today. Barriers to accessing appropriate and culturally competent care contribute to health disparities in transgender persons, as listed here. Thus, it is important that clinicians understand the specific medical issues that are relevant to this population. And my hope is to help to discuss many of those today. It's not just Annals of Internal Medicine that is exploring this idea. This is a scientific statement from the American Heart Association, actually published in 2021. That is excellent. I also encourage, especially our cardiology folks, to read this, but I think relevant for all of us. And in this article, they actually include this model here to the right, which is the minority stress model and helps to explain why groups of people who face systemic stigma and discrimination have higher levels of cardiovascular disease because of the inherent stress of being in that minority population. So I think an important consideration for us as well. Also, the American Thoracic Society has both a focused review article that is very, very good, as well as some cases that are very interesting and interesting for our study today. There's also this algorithm on the bottom right that I'll promote a little bit. I am involved in a team that's working on an algorithm for selection of sex marker on PFTs. I'm working with some colleagues at NIOSH on this. And this is part of a longer algorithm that is going to be presented at ATS coming up soon. And so if you're interested, please check out our poster. It's not just those specialties either. I wanted to make sure that I conveyed the message to everyone that regardless of the kind of medicine you practice, gender affirming care is relevant to your work. And so here's some other articles in some other fields as well. I want to talk about what gender affirming care is. And I have a definition that is pretty broad, and I'm going to go over that now. I consider gender affirming care to be comprehensive support for any gender diverse, and I consider gender diverse people to be anyone whose sex assigned at birth and gender identity do not fully align. For any folks who are questioning or who are gender diverse, including use of affirming language, mental health support, sharing of resources, general health monitoring, consideration of provision of gender affirming care, and overall support. I have an asterisk there on the mental health support piece because we could all benefit from mental health support, but we shouldn't pretend that it's easy or affordable to access for everyone and that there isn't associated stigma, especially for a population that has been so heavily pathologized by medicine for more than a century. And so while we want everyone to have mental health support, there are real reasons that people don't seek it and are afraid to seek it. And I think we need to acknowledge that as well. These are my 3 learning objectives as we discussed. And so to launch into the first, I assume that you already know about the LGBTQIA+ acronym, but just in case you don't, I've included some definitions here. And we're going to really focus on the transgender, non-binary, genderqueer, and queer communities today. I also just want to take a pause because we're not talking about intersex people, but we really should, right? So intersex is an umbrella term for variations in chromosomes, hormones, internal reproductive anatomy, also known as differences in sexual development or DSDs. I want to point out that disorders of sexual development is actually considered increasingly pejorative and we're no longer using that language. But some examples here are listed. And I also want to let you know that there is a grand rounds about this topic in June that you are all welcome to attend. That is a multi-part presentation. I also want to point out that gender nonconformity is not the same thing as gender dysphoria. And these terms are often confused with each other. And so gender nonconformity is the extent to which someone
Yep.
If someone could mute, that would be wonderful. Thank you. So the extent to which a person's gender identity, their role or expression differs from cultural norms as our society expects, right? And that is different than gender dysphoria, which is the emotional distress that's caused by a discrepancy between someone's gender identity and the sex they were assigned at birth. I do think that someone is still unmuted. If you could mute, that would be great. I think
Margaret Kaiser, please mute. Margaret Kaiser, please mute.
Thank you. I have a table here, some language that can be tricky in terms of we can use language in ways that aren't super supportive and validating of our patients. And one example is to say that someone is transgendered. We don't say that. We say that someone is transgender. Same thing with someone is a transgender. That's also not correct. We say someone is a transgender person. And we often fall into a space where we say things like, you know, your pronouns are really hard. Don't get upset with me if I mess them up. And I want you to not say that, right? Because when you say that, you kind of put on the other person that they should say, oh, that's okay. Or, you know, it's all right, don't feel bad. And our patients shouldn't feel like they need to make us feel better about misgendering them. And so instead, simply do your best. If you make a mistake, which you will, I absolutely do, correct yourself, apologize, move on, and then pledge to do better next time. And then below here, I've listed several terms that are outdated and offensive. And I don't encourage you to ever use this language. And that includes some things you might actually currently be using, like preferred name and preferred pronoun. We're moving away from that language because it implies a preference. And really, someone's identity is not a preference for you to acknowledge or not. It is their identity, and we need to acknowledge it. But also, FTM and MTF are often in medical records to help us keep track. But really, it implies a forced binary that isn't applicable to a whole lot of people. And so I encourage you to not use that language either. An example about how I talk about people in medical records specifically, you may see a note from me that says something like, Jane is a 27-year-old female, in parentheses, she, her pronouns, comma, assigned male, parentheses, who presents to established care, right? And so I'm not emphasizing the fact that Jane is trans, but I'm including it like I would anything else, right? Like hypertension in my descriptive line. I also often hear from folks that they have a concern about the grammatical correctness of they, them pronouns. And so I want to point out to everyone that they, them pronouns are already singular, and that is already grammatically correct. And so if someone was raising their hand right now, I would say, oh, someone raised their hand. I'm not sure who they are. Could they speak up? And all of those uses are singular, right? And so it's just kind of getting our minds in a space where we are comfortable using this language, but it's so important that we do that for our patients. I'm also often asked, okay, well, how many patients are we talking about here, right? Is it the 1%? Is it less than 1%? And really the answer is that it's complicated. This is a comic strip from a comic who I like very much named Sophie LaBelle. I encourage you to check out her work. But she acknowledges here through her characters that there is no trend of kids being trans or non-binary. It's simply that more kids have words to describe who they are and feel safe to come out. And that is absolutely in line with what I've seen in my practice. You may also be familiar with this study, as talked about here in the Charleston Gazette Mail from 2017, that identified West Virginia as having the largest number of transgender youth per capita in the country. And that's a super interesting study. It was conducted in an interesting way through some phone surveys of adults and then extrapolated to children. A number from the same organization, the Williams Institute out of UCLA, suggested that there were 1.4 million adults in the United States who identified as transgender. I encourage a different approach in this because not everybody identifies with the word transgender despite being gender diverse. And so when I do research, I use a two-step question as described here in box 1, where we ask about gender identity and sex assigned at birth separately, and then consider anyone who has any incongruence between those two questions to be gender diverse. And when we did that, for example, in Pittsburgh Public Schools, we found a much larger number. And so 9.2% of 9th through 12th graders in Pittsburgh Public Schools had a gender diverse identity. And you might be saying, okay, pediatrician, calm down. I'm not a pediatrician, right? I don't see kids. That might be what you're thinking. But in fact, this was a study conducted quite a few years ago. And so now these young people are your patients. And so increasingly, I think that we are going to see a whole lot of gender diversity in our clinical spaces, and we already are when we are keeping our eyes open to it. Back to our learning objectives. Next, identifying ways to make gender diverse patients feel safe, seen, and comfortable. But first, we need to understand why gender diverse patients don't feel safe, seen, and comfortable in our clinic spaces. This is an important quote. The transgender community is arguably the most marginalized and underserved population in medicine, and I agree with that. And there's also this higher prevalence of discrimination, which adversely affects their health and well-being throughout their life course. And that actually comes from the 2015 US Transgender Survey, which I'll be referring to a few more times during this lecture. Know that there is a 2022 survey that is currently underway, and so hopefully we have updated numbers here. I recognize 2015 is getting a ways away, but hopefully new data soon. But again, this data is from that 2015 study, and I don't think it's surprising to folks. I think this is the part that people have heard about, that 40% of transgender people, specifically in that survey, have attempted suicide in their lifetime, and that's nearly 9 times higher than the base rate for the population. And there's a whole lot of things that feed into that, including a higher rate of homelessness, feeling unsafe in a variety of settings, feeling discriminated against in community settings like public bathrooms, family misgendering, rejection. But the two primary factors associated with those mental health inequities are gender dysphoria, internal distress, and stigma and discrimination. And we know that adolescents and adults who are supported by their families and communities in social and medical transition have rates of depression and anxiety that are equal to or lower than cisgender people. Unfortunately, our current political climate is not one that is kind to gender diverse people. This is a map from the ACLU demonstrating all of the legislation that was lobbied against gender diverse people in the year 2021. Unfortunately, since the start of 2022, we have had more than 20 states pushing legislation that would, again, be harmful to gender diverse people, usually children. Alabama is poised to pass a ban on care as early as today that would ban care for up through age 19. And so we are creeping into adult territory as well. West Virginia is not innocent in this. We have an athlete ban, and you may be aware of what's going on in Texas, where the Texas governor and leadership has said that they are going to take children away from their parents if their parents are supportive of their children's gender diversity. Additional reasons that our patients don't feel safe, seen, and comfortable. A pretty significant proportion have been refused care due to being transgender, have been verbally harassed in our offices, have reported being physically attacked in some cases, and nearly a quarter have postponed care when they are sick or injured or need care because they're worried about being discriminated against. Half of trans people specifically, have reported having to teach their providers about their own health needs. 74% of medical students have reported receiving less than 2 hours of time in their medical curriculum devoted to caring for this population. That has changed in our medical school through a lot of activity by a lot of folks, including several in this department, so thank you. But that was the state of being for a very long time. In a relatively recent study, 9% of internal medicine residents felt comfortable prescribing gender-affirming hormones. And I haven't done that study in this population, but I think that may be a similar number here, and we're working to change that. Specifically here at WVU Medicine, we did a survey a couple of years ago where we asked some of these questions, and we found that a whole lot of folks said, we need more training on this. So here we are. We found that nearly a quarter of folks acknowledged these significant barriers to care. Almost everybody acknowledged that these patients have unique health risks and needs, but unfortunately 1 in 10 people actually endorsed a question that indicated bias or active discrimination against transgender patients, which is profoundly problematic. As a result of that study, we have launched quite a few initiatives here, most of them led here by this individual, Dr. Molly Factor-Leggett, including across the board training, bringing in a national expert, making sure that our non-discrimination policies were updated to include gender identity and gender expression. That is now also happening at the level of the medical school. And so across the board for our patients, but also for our coworkers, this is not a space where we will condone discrimination on the basis of gender identity or gender expression. That unfortunately is still needing to be worked through with our insurance products for our workers. If you have PEIA, PEIA actively denies coverage of gender affirming care. And so that's something that we're working on in our health system. In the Department of Medicine, I want to give some kudos here to Dr. Jenna Sizemore for her innovation grant in Appalachian Standardized Patient Experience, enhancing cultural competency through increasing diversity of WV STEP standardized patients. I have been involved with Dr. Sizemore in this process, and so far to date, she has trained 18 residents through 5 sessions with a trans standardized patient who is actually a person of trans experience. And there are 13 additional residents scheduled for this year. By the end of next year, all residents in internal medicine will have had this training. It's precepted by Dr. Sizemore, Rickard, and Safka. And if you have not had the opportunity to participate, especially if you're a faculty, you are welcome to join and observe and participate in this kind of training and join as a preceptor if you're interested. And so definitely something to consider. And I'm so grateful that Dr. Sizemore is doing this important work. And so now we kind of get to ways we actually help our patients to feel safe, seen, and comfortable in our health system. And the number one way we do that is to use patient's name and pronouns in all settings they desire. That is out loud, that's in our health record, in our surgical timeouts, and also when they are unconscious. I feel like that's the one where we sometimes slip. We need to affirm our patients all the time, even if they can't hear us. And I would argue, especially if they can't hear us. I encourage you to introduce yourself using your name and pronouns, and I'll demonstrate that here in a minute. And also not to tolerate discrimination from coworkers. We are happy through use of this email address, which goes to Dr. Factor-Leggett. We are happy to do additional trainings in sections, divisions, and groups who need it. But please don't tolerate discrimination against our patients or against folks that we work with. And when you do make a mistake, because you will, don't make an excuse, apologize, correct yourself, move on, and do better. We can also be affirming in Epic, which is wonderful. So you should know about this. We have a SOGI form. You can access this by clicking on the banner column in the left on the gender marker, and you can update that information. You can also change a patient's affirmed name. That puts it in quotes. We're working on making that just the name that you see and not a name in quotes. But if you see a name in quotes, think to yourself, this is probably the name the patient wants to use because somebody has updated that information. Patients can actually do this themselves. So they may be the one who updated that information, and they can do that through MyChart. We're currently developing a resource that can be posted in clinic spaces that will instruct patients on how to actually navigate this, but it's pretty straightforward. And so I promised I would demonstrate. Hi, I'm Dr. Kidd. I use she, her pronouns. What name and pronouns do you use? What name can I call you? There's a variety of ways you can ask this question, but the goal here is to make sure that you're using language that your patient wants you to use when you talk to them. And then, is it okay for me to use this name and pronouns in front of your partner or your family, in your medical record for other medical providers to see in our health system? And then I'm often asked, okay, well, what do I do for the patient who says, why are you asking this? My response to that patient, although that's very uncommon, that experience, but my response is, I want to make sure I'm respectful of all my patients, and that includes how I talk to and about them. Okay. Ways that we create spaces that are affirming are also important to consider. And so that involves staff training, that involves developing systems to ensure that affirming names and pronouns are used consistently. It's designating single occupancy restrooms as all gender, as our medical students pushed us to do several years ago. And so that's why there are several all gender restrooms in the HSC. We need to do that everywhere. You can also display a pin or a button or a ribbon. I'm wearing one now, that shows that you are an ally. And you can also actively advocate for non-discrimination policies and legislation that specifically protect against discrimination on the basis of gender identity and expression. And these things are also mirrored in that article in Annals that I pointed out earlier. And so I wanted to include that box here. And that brings us to our third learning objective. And this is the one where I want to spend the most time today. I've included here some tables that I hope will be helpful. This lecture is not intended to cover all of the ins and outs of gender affirming hormone management. That being said, I actually consider that part the easier bit. You do far more complex medicine every single day. This is pretty straightforward. And so I've included some tables to get you going if you've not already explored this part of medicine for yourself. There are some anticipated changes from both estradiol and testosterone listed here, as well as some possible side effects. Side effects are in the eye of the beholder. And so some things like breast tissue growth from spironolactone are actually considered a desired and anticipated change in this patient population as opposed to a side effect. But these are listed here for your review, and I'm confident that you already are aware of most, if not all of them. There are different guidelines for what we do in terms of baseline screening, as well as follow-up labs, imaging, things like that, when using gender-affirming medications. And like with all guidelines, they conflict a little bit. And so this is my attempt to make one table that lists all of the things you should do when initiating and monitoring hormone management, including blockers, which is something that I use much more frequently in a younger population, the GnRH agonist, but very often spironolactone is used as a blocker in adults. But these are listed here, and these are guidelines summarized from the Endocrine Society as well as UCSF guidelines, and that is what all of the superscript here is. It looks rather complicated in this list, but I promise this is the whole of it. And once you get going with this, it's pretty easy to rattle off these guidelines. Also good to know is what are the medicines we use? What is the route of those medications, the frequency, the starting dose, and the maximum dose? And all of that information is included in this table. And so I use this pretty frequently as a reference when I forget exactly what my starter dose or what my max dose needs to be for a particular agent. And then this is another one of those tables from the piece in Annals. And I think it's important to recognize that the criteria for establishing that a patient is gender diverse is that the patient tells you that they are gender diverse. We are not the experts in anyone else's lived experience. We are not in their brains. And whether or not they have gender dysphoria is a different thing. There are some diagnostic criteria there, but persistent gender identity that doesn't align with sex reported at birth and capacity to make medical decisions and not having obvious potential confounding mental health concerns. That is the criteria according to this piece in Annals. And so you are all entirely capable of acknowledging someone's lived experience, right? And so we don't need a subspecialist in gender affirming care to tell us if a patient is gender diverse. Medical management can be done by primary care physicians and primary care clinicians more broadly with sufficient knowledge of transgender medicine. And this is the first in a series of lectures that can certainly do that for you, and can determine whether patients are transgender. And although hormones are reasonably safe when monitored, you need to be aware of potential adverse effects, just like with all things. We can get assistance from our mental health colleagues, from our endocrinology colleagues, and we can do surveillance and screening based on what body parts people have. The first case I want to explore with you today is an outpatient clinic setting. It's Friday afternoon, the clinic is packed, and at 4:30, you have a new patient spot because you're brave like that. And your new patient initially checks in, but then that visit's canceled. And so you could think, okay, start to the weekend. Or you could go to the front desk and ask what happened here. And so you do that, and the front desk staffer says, oh yeah, that patient checked in 15 minutes early, was in the waiting room. She, sorry, I'm new about this stuff. I took the training, but I get confused. She asked to be called a different name than what was in the chart. And so I told her to tell you that. But then the nurse called the legal name because that's what the nurse had. And she got upset and left. And I had to help a line of other folks. So I didn't really get a chance to talk to her about that. This case is intended to remind you that there are a whole lot of people who interact with your patient before you do. And any of them can make that patient feel unsafe. And so, yes, this is a disrespect sort of situation, but it's also a safety concern because outing this patient in the waiting room may actually lead to physical harm for that patient. And that's an important thing for us to remember. We need systems in place to help protect our patients and make sure that situations like this don't happen. And it is incredibly easy for situations like this to happen. And so this is something we all need to be thoughtful of. The next case, and all of these cases are inspired by cases that I have worked with personally. And so this is a case of a 20-year-old transmasculine patient who presents to me for intermittent left-sided pelvic pain. And I was concerned for intermittent ovarian torsion. This did not happen in our health system, but another. But I did order a transabdominal pelvic ultrasound for pelvic pain. I certainly could have been more descriptive in that line, and that was on me. But the read that I got back measured a prostate. This patient doesn't have a prostate. And this is an example in my mind of an anchoring bias that in radiology, because the gender marker was male, because this patient had a legal gender marker change, that we were looking at a prostate and not a uterus. A small uterus, mind you, but a uterus, right? And so I could have done much better by giving my radiology colleagues more insight into what I was concerned about, right? And letting them know that the gender marker was not going to align with the anatomy they were seeing. Additionally, I could have helped by filling out this organ inventory. And so this is available in Epic for all of our patients. You can select what organs are present in someone's body and what organs are not. And this can help with imaging concerns as well. That same patient, though, follows up a couple months later, and now he's turned 21 years old. And he knows, because you have done your due diligence and explained about pap smears, he knows that he's due for that. And he's pretty anxious about it. And he asks you, okay, well, are there any options that don't involve the speculum? Because I'm not interested in having a speculum exam. And you may say, well, that's just part of it. That's what we do. But actually, there are options for HPV only screening. And you can get this through a blind swab that you do or that the patient does, or you can do a swab with your cyto brush and broom spatula that is over your own fingers, right? And so you can actually feel the cervix and you can slide those tools over your fingers to get the sample. But regardless, once you have the sample, here's the algorithm we use for HPV primary screening, assuming that you're not able to get cells adequate for a PAP from that kind of procedure. Notably, if someone is on testosterone for any length of time, they tend to have cervical atrophy. And so getting an adequate specimen for a pap smear is much more challenging. And so you should always order HPV testing on someone who's been on testosterone. Our next patient is a 35-year-old female who was admitted for pancreatitis. She was advanced to a full diet. She's ready for discharge. We are good to go here, and you're reconciling the home meds. So I imagine this is the intern who's trying to sort through the home meds, but maybe it's any of us, right? And you see estradiol, you see progesterone, you see spironolactone, and you think, okay, estrogen, progesterone, well, woman stuff, that's maybe some birth control. But the spironolactone doesn't make any sense because this patient's blood pressure has been super normal, even when she was pretty sick. And so we're going to stop that one. We don't need that spironolactone on board. But what you might not realize is that this is this patient's gender affirming hormone regimen, and that spironolactone is acting as a blocker, not as an antihypertensive. And so it's actually inappropriate to discontinue the spironolactone. The next case is a previously healthy 40-year-old male presenting with a COVID-induced myocardial infarction. This patient was diagnosed with mild hyperlipidemia during this admission and was on testosterone cypionate injections. The testosterone cypionate injections were discontinued by the primary team due to the concern for hyperlipidemia. The patient was pretty distressed when he was told, okay, we're going to stop the testosterone, and he demanded to leave AMA. Because what the team didn't really realize is the testosterone was not being used for low T or low libido or low mood, but actually was his gender affirming regimen because this person was assigned female. And stopping this medication, even though we absolutely need to have a risk benefit conversation about the lipids, the association there is pretty loose. We don't have strong evidence for how much testosterone increases your lipids by any particular measure. But stopping this medicine without an extensive conversation, usually with the patient's gender care provider, which may be their primary care provider, that would be something I would not recommend for an inpatient setting. Right? This is an important conversation, but not one that needs to happen at this point and can be profoundly distressing to a patient who needs to have some faith and some confidence in the healthcare system for receiving care in the future based on this most recent MI. The next case is a 75-year-old male who was admitted secondary to septic shock as a transfer. He is currently obtunded. He arrives on the floor and you quickly go to assess him. And during your initial assessment, the nurse is attempting to place a Foley catheter, but the patient is found to have marked clitoromegaly and otherwise female appearing genitalia. The patient's wife arrives at bedside and shares that the patient's stepchildren do not know that he is transgender and asks that you ensure they don't find out. And so our responsibility to this patient is to protect this information about him until and unless he is ready to share it. And so we need to make sure that we don't out him to his family or to others that don't need to know about his gender diversity. And that could be a safety issue, but also it is respecting our patient and their identity. And the last case I want to make sure we cover today is that of a 30-year-old trans female patient who is actually transitioned to comfort measures after multiple courses of chemotherapy for lymphoma that was pretty aggressive. This patient's family, unfortunately, consistently misname and mispronoun her in the room, even when she was awake, alert, and oriented. The patient's decision-making capacity is intermittent. And the team has a discussion with the team and decides to discontinue the estrogen patches that she's been using for gender-affirming care due to concern for thromboembolic event. And certainly there is concern here for thromboembolic event, and that is a very real consideration to have. It's important to note that there is a difference between 17-beta estradiol and ethinyl estradiol. Ethinyl estradiol is what is in birth control pills, and 17-beta estradiol is what is in gender-affirming estrogen, such as oral and patch estrogen. Patch estrogen has the lowest level of thromboembolic event, and so this patient is already on the form of estrogen that I would recommend in this circumstance. And absolutely, people have stopped their estrogen due to concern for thromboembolic event during a cancer diagnosis and care for cancer. But to stop a patch without a conversation with the patient, especially a patient who's comfort measures, could be very harmful, both to mental health, to this patient's well-being overall, and to this patient's quality of life for the remaining time that she has that life to live. And so it's very important that we don't just arbitrarily stop gender affirming hormone care. You can imagine as a cisgender person, potentially, if someone just turned off your sex hormone, they would put you into immediate menopause if you were assigned female. They would absolutely have an impact on your mental health and well-being if you were assigned male. These are important considerations, and we should not make them arbitrarily. And so to review the learning objectives that we've made, hopefully some progress on so far: evaluating language, identifying ways to make patients feel safe, seen, and comfortable, defining health concerns critical to care of this patient population. I hope we've achieved some of that. But I also want to mention that if you are someone who says, okay, but I really want you to do the talk where you talk about how I use the hormones and give me some examples of that, I'm happy to do that too. I do think that is the easy part. I think all of this other bit, how we reshape our health system to be more affirming, is much more challenging. But I will happily teach you the hormone bit too. And Dr. Perini and I actually are in the process of scheduling this. So we're doing a 2-hour workshop on gender affirming hormone management later this spring, date to be determined. Everyone is welcome. Trainees of all levels, including faculty, are highly encouraged to attend. Please email me if you are interested, and we'll try to schedule it during a time that you are available to participate. Additionally, Dr. Perini and myself are working on developing e-consultation through Epic. And so hopefully in the future, if you are caring for a patient, you could easily send us an e-consult if you had any questions. But in the meantime, you are absolutely welcome to email me or to in-basket me anytime with any patient questions that you need help with. I'm happy to be that assist. I have some recommended reading for everyone. These articles include the piece in Annals of Internal Medicine that I've been referring to multiple times during this presentation, as well as the World Professional Association for Transgender Health's Standard of Care guidelines. This is version 7. Know that version 8 has been promised. I've reviewed version 8. It was up for comment and that period has now ended. And so we're hoping that version 8 is released by the end of this calendar year. And so look out for that. I think there are some good changes coming in version 8. As well as this article here that talks about the curriculum for internal medicine residents for supporting LGBTQ patients more broadly. I thought that was a well done piece that was actually led by Dr. Aloha Ufamata, who's a colleague of mine from Pitt, and Dr. Kristen Ekstrand, who's actually come previously to speak at WVU. And then I have an article on the bottom here that I have written that's specifically about the care of gender diverse young people, but includes all of those tables that I've been using throughout this presentation about medication dosing and side effects and things like that. And so I'm happy to send that to you if those tables are helpful. I also want to thank Dr. Sizemore and Gannon for their help with cases presented today. And I'm glad I think we have plenty of time for me to answer questions and to go into more detail specifically about hormone management if folks are interested in that. And so I'm going to close my slides so that hopefully I can see you and answer those questions. And I'm looking in the chat right now. Yes, and so Dr. Silverberg has linked the paper in the chat. And then differences in estrogen for treatment. Yes, and so that's an important consideration. The differences between ethinyl estradiol and 17 beta estradiol are very different in terms of clot risk. And increasingly we're seeing folks continue, sometimes in the setting of anticoagulation, but often continuing on their estrogen, even in situations where they would be at higher risk of blood clot. Next question. So a patient on estrogen who does develop thromboembolism, really great question, Lisa. And that is often use of anticoagulation in the setting of continued estrogen use. And so we very uncommonly stop someone's natal estrogen due to concern for thrombogenic risk. And so we would, again, not necessarily stop someone's estrogen for gender affirming care. We may change the route to patches, something like that. We may lower the dose. We may couple that with anticoagulation. And we certainly are going to make sure that that estrogen level is within natal limits for someone who is assigned female. Right? We want to make sure that we have careful monitoring of hormone level to reduce that risk as much as possible. Additional questions?
Hey, Casey, good morning.
Good morning. How are you, Dr. Kosky?
Oh, very good. Hey, I'm learning lots from this session. So I just wondered if you could comment from your experience with doing research or clinical trials with this complex environment for these patients and legal issues, and because clinical trials have their own special issues. Just wonder what your experience has been today.
Yeah, so I think we, as a medical community and as a research community, have not done our absolute best in terms of making sure that these patients are reflected in research. And that is true of research that is directly applicable to this patient population, including things like PrEP, right? And so when we have studied HIV medications and PrEP more broadly, we have not always considered how people differ in terms of how they have sex, how they use body parts, what body parts they have, whether or not someone is enrolled in the trial in numbers to reflect how we should dose medication or change medication recommendations based on those things. I think that's one of the major shortcomings of the literature to date. And I think more recent studies have attempted to address that, but we still have Descovy that is not approved for use in cis women because we didn't include them in the study. And so I think in terms of gender identity in clinical research, we need to be thoughtful about how we recruit and how we power our research, but also how we assess who is gender diverse. And that's, I think, where a lot of new informatics approaches are important. And that includes things like the two-step question for gender identity that can be helpful at identifying especially young people who don't associate themselves with the word transgender. It is not at all uncommon for a young person to check the box that says, I identify as male, and to then check the box that says, I was assigned female. Right? And that may be the only information you have that tells you that this patient is actually gender diverse and may have different health needs, may not fit into the categories that you previously assigned them based on your research goals. So I think there's a lot to consider there in terms of how we do our screeners, how we ask our questions, how we power our studies. The world is not as binary, most certainly, as we have expected, and our research needs to not be as binary as well.
Thank you.
Absolutely. I'm seeing a question in the chat from Dr. Silverberg. How does one gently correct a coworker who doesn't see the point in using name and pronouns, especially when the patient can't hear them? I think we model good behavior. That's number one. I think we model that we are respectful of our patients. And we say, and so when someone mispronounced or misnames someone, I correct them, right? And I say, oh, John uses John and he, him pronouns, right? I think if that is happening repeatedly and someone doesn't at all accept that they need to be doing that, I think that's a role for us to have additional education. And I think important leadership, and I think our health system has really started to do that, and that we have our leadership saying, no, this is the expectation. Providing comprehensive, good care for our patients includes being respectful of those patients and their identity. It is not for us to decide, it is for our patients to decide how they want to be addressed. And we need to respect that in all spaces. And then the current state of affairs with regard to education and our development of nursing and APP student curriculum in our undergraduate and graduate programs. That's a wonderful question. And my hope that is moving as quickly as medical education is adjusting as well for our medical students. I know that I provide a lecture for one of our nurse practitioner programs. So I know there's some content there, but I'm super open to hear from others what that curriculum looks like. And I'm happy to collaborate if we need to do some advancement in terms of making sure this content is in that curriculum as well. Work on spirometry. Yeah, Dr. Chapman. Yes, so PFTs are complicated. And I think there's a whole lot of thought about whether or not we even ask people. We make a lot of assumptions based on what's in the medical record. And that's important too, because especially in a NIOSH space, whether or not your PFTs are normal can determine what kind of occupation, what kind of role you can have. And we have patients who have their gender marker changed in their medical record, but who may have gone through female puberty despite having the M in their chart, and may look like they have restrictive lung disease because they were exposed to estrogen and have a chest cavity that's appropriate for the size of the puberty that they had. And so there's a whole lot there. There's also a lot of interesting content in the cystic fibrosis space, where the role of estrogen in your lungs can affect neutrophil action. And so having estrogen on board can actually make your outcomes in CF worse. Wearing a binder can be complicated for both spirometry and for CF, as well as other lung disease. But wearing a binder is an affirming measure that a whole lot of people take to create more of a masculine silhouette of their chest if they've not had top surgery. So really, really important considerations and things that we were not taught to think about, but that we still need to think about and continue to learn and grow in this space with our patients. Other questions? Sandra.
Hey, Casey, I just wanted to really thank you for this lecture, and also to note that even within our student populations, that this is important. We had an undergraduate student who was very sensitive to the issue and of trans students, and the rules of engagement about our damn name badges became an issue that was going to force someone to use their dead name. And I don't know that you use that language today about the dead name, but in our students, we were able, through our DEI committee and the persistence of this student, to get the policy changed so that it's not, some damn legal document that's going to, unglue this poor student's life. And so I wonder what the School of Medicine's stance is on name tags and how they approach the name tag issue. And the hospital, by the way, doesn't give a you know what and where what you put on your name badge, as long as it's not inappropriate language. So thank you for this lecture. This is so needed. And, you know, as a person from the LGBTQ community, you know, I just can't tell you how important this is, you know, because for years, even before I was out, every time going into the OBGYN office, asking if I was married, and if I said yes, or if I was partnered, the next question out of their mouths would be, what birth control are you using? Well, if you're not using any, are you trying to get pregnant? And so just going through all of that felt so disrespectful. So anyways, I really appreciate your lecture. I struggle with pronouns as a gay person because I had to hide for so many years. It's hard for me not to use pronouns that I think are appropriate. So I'd like straight people or people who disagree with this to go a day without using a single pronoun to describe your relationship or your family and see how it feels. So thank you so much for doing this. I appreciate you.
Absolutely. Thank you so much. I think that your comments are spot on. I agree that we need to make sure that our name badges are able to reflect our trainees in the way they want to be reflected. That's a critically important space, and one that if it's not been raised with the School of Medicine, I'm happy to discuss. I think it's also important in our teaching, right? We are, for the most part, clinicians, many of us, but also instructors and educators. It is not uncommon that we are giving lectures, and we may do things like divide people, at least in problems that we're having our students solve, into male and female. It's a binary that we have fallen into historically for a very long time, but you can imagine how your non-binary student who's sitting in that class feels. And that has absolutely happened here at our institution. And so we need to be thoughtful. We need to be mindful that the world is not as binary as we thought. We need to be respectful of pronouns, just like Dr. Cotton mentioned. We need to be able to reflect who we are in all spaces and have that be respected. This is not just a WVU medicine concern. This is a national concern that is actively being discussed. Our trainees are deciding whether or not they want to even rank us based on how supportive they feel we are towards LGBTQ trainees, right? It is critically important that we consider this in everything we do, because we want to have a space where we have a diversity of learners, because that only contributes to our overall growth. And I see there are a couple other comments. Agreement with Dr. Cotton.
Thank you so much.
Yeah, 100%. And remembering pharmacy and other health professions when advancing education. Absolutely. And again, I am not as familiar with training that is happening in other academic spaces within our health sciences system. If there are spaces that I can be helpful, I am happy to do so. And I know that Dr. Factor-Leggett is as well. And also, if there are champions in your spaces that want to take on this mantle and to help us with broader initiatives, we are so grateful for you and your willingness to do that. And then, yeah, wheels of change can be slow, but also we've made some progress. I think there's a long way to go here, but it's important to acknowledge how much incredible work has happened through the work of folks like Dr. Sizemore and many others in this space. Yeah, not shaming folks who aren't knowledgeable. Absolutely. Most of you, if not all of you, did not have the opportunity to learn this content in your medical education or your training background, whatever that was. That is changing. And your trainees, just like Dr. Cotton mentioned, it was a student who really pushed for that change on the name badge, someone who was persistent, right? It is our students who are the reason we have all gender bathrooms in the HSC. It is our students who will be ahead of us if we are not careful about making sure that we catch up. Your students already have had more training than you, because I've seen to it that your students have had more training than you. And so it's my job now to help you catch up to them. But we will get leadership from our young people, because they're changing the culture of our entire society on this issue, and not just in medicine. So I don't know if there are any other questions. I certainly know that y'all have work to get to, and I appreciate your time this morning on a topic that is obviously very near and dear to my heart. Right. And please feel free to email me with any additional questions. And definitely, if you want to participate in the training that Dr. Perini and I will be doing later this spring, we would love to have you.
Dr. Kidd, this is James Messer from the WVU School of Nursing Beckley Division.
Hello.
Is
Yes,
is it possible to get a copy of your slides?
absolutely.
And I am interested in that training. So
Wonderful. If you could drop me
yeah.
an email, I'll make sure you get both the slides and information about the training.
Okay. Are you at hsc.wvu.edu?
I am. I'm going to put my email in the chat right now. I'm casey.kidd@hsc.wvu.edu.
Thank you again. It was great hearing you talk.